This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2013, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Esophageal Pressure Monitoring to Guide Ventilator Management. Upon completion of this AARC webcast, participants will be able to describe the rationale for using esophageal balloon tip catheters to assess lung mechanics, describe the procedure used in placing catheter and obtaining measurements, summarize available research for esophageal pressure monitoring to guide mechanical ventilation in ARDS and ALA patients, discuss the validity of using esophageal pressure measurements as an estimate of pleural pressure in critical illness, and discuss case studies using esophageal pressure monitoring. I am pleased to welcome Carl Hinkson. Carl is a respiratory therapist, adult critical care specialist, and neonatal pediatric specialist. He is the interim manager of respiratory care at Harborview Medical Center in Seattle, Washington. Carl earned his respiratory therapy degree from Highline Community College, his bachelor in respiratory therapy from the University of Kansas, and his master's of science degree in respiratory care from Northeastern University. Neither Carl nor I have conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Carl, welcome to the program.
Thank you, Shauna. It's my pleasure to be here online today with everyone discussing esophageal pressure monitoring and how to guide ventilator management. I became involved in this a couple years ago when an attending came to Harborview, and he had some experience at Beth Israel in Boston, where Dr. Talmore and Ray Ritz work, and he brought with him his experience and understanding of it and introduced it to us here at Harborview, so I've kind of developed a little bit of expertise about it. So first off, to begin the discussion, I'd like to show everyone this slide. This is a pressure volume curve I'm sure everyone's familiar with. On this side here, you see that this is the inflation point and then exhalation. And we know that hysteresis occurs at these points, and those problems represent the closing of the alveoli, and here represents the overdistension. So the strategy that began 2 decades ago was trying to ventilate patients with ARDS and ALI within this safe window here, avoid overdistension, and you wanted to try to avoid the zone of derecruitment and atelectasis. A lot of that was accomplished with the ARDSNet trial that used tidal volumes of 6 mLs per kilogram and kept the plateau pressures less than 30. That was the first study that used ventilator management as a method for reducing mortality in ALI and ARDS patients. This figure here represents a post-analysis of those patients that looked at those patients that had higher FiO2s and lower FiO2s and looked at their percent of mortality. And this particular graph here looks at the mortality for those patients that had more than 50% and more than 5 of PEEP. This particular one here looked at those that had more than 50% and more than 10 of PEEP. And the mortality of those on this particular side that had more than 10 of PEEP. And what you can get from this graph is that if you required a lot of oxygen and a lot of PEEP, your mortality really didn't differentiate between the ALI, the acute respiratory failure, and the ARDS group. Whereas in this particular one, there was a significant improvement in mortality in the ALI an acute respiratory failure group versus the ARDS group. So it's still at this point in 2007, even though that we had improved mortality with lowering tidal volume, we still had a lot of work to do in trying to find a strategy that would improve mortality in ARDS patients. So there have been several PEEP studies that have tried to answer on how to set the PEEP, how to best set PEEP. The ARDSNet group had their own study, the ARDSNet alveoli study. What this study was a low PEEP, high FiO2 ladder versus a high PEEP, low FiO2 ladder. And the protocol was the lung protective strategy that they used in ARDSNet, and they found no difference in mortality whether they used high PEEP or low PEEP. The LOVE trial used a pressure control for 4 to 8 milliliters per kilogram, but they titrated their plateau pressure or their peak pressure less than 40 centimeters of water pressure. They used aggressive PEEP and recruitment maneuvers. They saw no difference in all-cause mortality, although they did see less critical hypoxemia and less hypoxic death. The EXPRESS trial used PEEPs of 5 to 9 and versus high PEEP. They saw no difference in mortality, but they did see more ventilator-free days. What I would like to draw everyone's attention to is that these are 3 very large trials that tried to find the best method to set PEEP, and ultimately really found no way to do that. But they all used protocols that looked at only airway pressures. They didn't use any other values to guide their ventilator management. So that brings us to esophageal pressure monitoring. If you're not familiar with it, esophageal pressure monitoring is the use of a balloon-tipped catheter that measures pressure in the esophagus and is used as a surrogate pressure for pleural pressure. Knowing pleural pressure, you can determine what the transpulmonary pressure is, and you can also estimate work of breathing. You can consider that the transpulmonary pressure is the distending or static or stress pressure of the lung. This requires simultaneous measurements to be made at both the pleura and the airway. In the case with esophageal pressure monitoring, we are simply substituting the esophagus as a surrogate for the pleura. In this cartoon here, what we're going to see is that this represents the esophageal balloon. And the esophagus is basically a thin, floppy muscle or membrane that is in direct contact with the lung. If you insert the balloon and inflate it with a small amount of air, the pressure that is generated by the structures surrounding the balloon will transmit to the balloon and can be read by a monitor. And as you can see from this diagram, there's a lot of different pressures in the chest cavity that can affect transpulmonary pressure. How is this accomplished in the ICUs? There are several pieces of equipment commercially available that can deliver this technology. As of right now, the CareFusion and the G5 ventilators are the only 2 ventilators that I'm aware of that have this capability. Full disclosure, I have no financial interest in either of those companies. We actually have both of those ventilators here at Harborview. There's also an old bicore pulmonary monitor technology if you're lucky enough to have one of those. This is an example of the CareFusion's esophageal balloon. And this here is called a Cooper surgical esophageal balloon. If you do not have one of those 2 ventilators, you can still do esophageal pressure monitoring, but the setup is a little bit more complicated and requires a little bit more know-how. You would require to use the Cooper surgical setup and hook it up to a pressure transducer connected to your cardiac monitor. A little bit more know-how is required for the G5 and overhead monitor. As you manually inflate the balloon. The nice thing about the Avia is that it automates many of the features for esophageal balloon pressure monitoring, such as testing for leaks, calibration, stuff like that. The esophageal balloons come in two sizes, 8 French for adults, 5 French for pediatric. The technique for placing the catheter, this is one of the most challenging aspects of using this technology to assess lung mechanics, is the actual placement of the catheter. Through experience, I can tell you you're probably better off icing the catheter beforehand, particularly if you're using the Fusion variety. Once you make a couple of attempts at placing it, the plastic tends to warm up and will kink on itself. Your general technique is to insert the catheter through the esophageal sphincter approximately to 60 centimeters with the teeth, but you're going to drop it all the way into the abdomen. You're going to inflate the balloon and then read the pressures that are on the waveform scaler. And then you're going to press on the belly. What you should see then is positive deflections that on your waveform that correspond to you compressing on the belly. Then you slowly withdraw the catheter, and then you wait for what are called cardiac oscillations to be seen on your waveform. Typically this is at 40 centimeters with the teeth. Cardiac oscillations are a sawtooth pattern that correlates with heart rate. On this visualization here, you can see the red arrows are pointing to cardiac oscillations that are visible on the waveform scaler. Another aspect of this is it does require some skill to read the cardiac oscillations, as in my experience, the morphology or the shape of the cardiac oscillations is not always the same. You sometimes have to play with the waveform sweep, adjusting it from perhaps 12 seconds to 6 seconds up to 20 seconds to visualize the cardiac oscillations. I think it is best that if you visualize the cardiac oscillations, you count them and match them up with the cardiac monitor to ensure that you actually are witnessing cardiac oscillations and not artifact. Once you have visualized good cardiac oscillations, you want to confirm your placement of the catheter with the chest X-ray. This is a very important step in the process. The catheters are mostly radio-opaque. This is a chest X-ray of a Fusion catheter, and it has very distinct shape. The tip of the catheter should be retrocardiac, and the tip should be in the bottom 1/3 of the lung. With the tip retrocardiac, then you know that you have proper placement. You can begin taking measurements. One of the reasons I am very adamant about getting chest X-ray confirmation is this is a chest X-ray from a patient who was not very healthy, had very severe ARDS. We had placed an esophageal balloon. It was there for several days, but the readings were kind of abnormal. We then came in one day and observed on the chest X-ray that the esophageal balloon had actually coiled in the mouth. It actually was never in the esophagus. But once you inflate the balloon, it will measure any pressure that is generated. And this is a very ill patient that had a very edematous mouth. There was a lot of fluid, and there was actually cardiac oscillations. And I think what happened is, in this particular instance, the tip may have leaned up against near one of the arteries in the neck and given us a false sense of security. That's why it's very important to get cardiac oscillations to avoid mishap. For spontaneous breathing patients, you can also do something that's referred to as the Bader maneuver. In the early experiences with esophageal pressure monitoring, which were mostly done in healthy spontaneous breathing patients, they would do this maneuver where they would have the patient take a deep breath, and then they would see a simultaneous negative deflection in the esophageal pressure and the airway pressure tracings. Since the esophageal pressure is a surrogate for the pleural pressure, when the person takes a spontaneous effort, the esophageal pressure should drop to negative before the airway pressure. And as the patient exhales, the pressure should rise to positive. This is not necessarily an easy maneuver to perform on a critically ill and heavily sedated patient. That's why it's very important to visualize the cardiac oscillations and then confirm it with a chest X-ray. Taking measurements, you want to be sure that you have proper placement of the balloon, but then you should want to have the head of the bed up at least 30 degrees to minimize the effect of the mediastinal contents. The heart and the other mediastinal contents can press on the balloon and change the values. You also may have to heavily sedate or paralyze your patients. Some institutions that follow this will paralyze patients in order to gain measurements. Some tricks that we have learned is that we can also increase the respiratory rate on the ventilator until the patient stops overbreathing, and then you can take your measurements there. So what factors can impact measurements of the esophageal balloon? This is a diagram taken from a study by Loring where they did a cross-sectional chest CT scan of a lung. In the top box, you can see that the transpulmonary pressure is 9, the airway pressure is 7, and the esophageal pressure is, the airway pressure is 16, and the esophageal pressure is 7. Over here, you have the the transpulmonary pressure is 14, the airway pressure is 16, and the esophageal pressure is 2. What this is supposed to represent is that there are regional variations in transpulmonary pressures that are caused by regional variations of esophageal pressure. Your esophageal pressure is not the same in any one spot. However, retrocardiac probably gives us the best global view of the pressures in the chest. If the balloon is too far up in the esophagus, too far towards the head, the texture of the esophagus is tighter, which will give you different values than if it's retrocardiac. The picture on the left is inspiratory, and you can see the values there. So the key point in this is that having the balloon tip and having the balloon resting retrocardiac will give you the best global or average values of the entire chest cavity. Obesity is also a condition that can impact the measurements. In this study here, they took 51 subjects with high body mass indexes and compared them to 10 subjects with a body mass index of less than 30. And the esophageal pressure at the resting volume for the obese patients was 3, and when as high as 25.7, and the non-obese patients was 0.7 to 12. So you can see here on this graph, you have your control patients here, and you have your obese patients here and up here. So this obesity and the body habitus that rests on the balloon can increase the pressure and change your measurements. And this needs to be taken into consideration when attaining measurements and interpreting them. Patient position also impacts this. This was a study done by Washuko that looked at different patients. They took the same patients, gave them an esophageal balloon, and had them sit in different positions. So the average, the mean transpulmonary pressure for an upright patient was 3.7, but by merely laying flat, that same transpulmonary pressure dropped to negative 3.3. So these differences were attributed to changes in lung volume, simply going from upright to supine, the compression of the balloon by mediastinal contents. And Washuko recommended using a correction factor of adding 3 whenever you had to do measurements using an esophageal balloon on supine patients. In this graph here, these are the volumes or the transpulmonary pressures while the patient was upright, prone, and laying on their left lateral. Even laying prone did not impact the measurements as much as laying supine, because the balloon was not being compressed by the mediastinal contents. When the patient was prone, the balloon was on top of the heart and wasn't being compressed. So transpulmonary pressure. again, transpulmonary pressure is the distending pressure or lung stress of the lungs. And I like to tell people that it can be measured at 2 points, at end inspiration and end expiration. End inspiration or inspiratory transpulmonary pressure is a maneuver similar to getting a plateau pressure. You're going to do a breath hold at the end of the delivery of a breath, and then you're going to take a simultaneous values of the airway pressure or the plateau pressure and the esophageal pressure. Remember, transpulmonary pressure is a value where you measure 2 values at the same time and do a calculation. Expiratory transpulmonary pressure is the pressure at end exhalation or in between breaths. And you do the maneuver similarly as you would be checking for auto-PEEP. So you do a breath hold, no volume is delivered, then you check the transpulmonary pressure at end expiration, and that tells you how the lung distending pressure is between breaths. Inspiratory transpulmonary pressure can be used to guide tidal volume management during mechanical ventilation. In this, your goal is to keep your inspiratory transpulmonary pressure less than 20, or 25 depending upon which guideline you're using. Inspiratory transpulmonary pressure is calculated by subtracting the esophageal pressure from the plateau pressure on an inspiratory hold, so it's PES minus plateau pressure. Some people look at this as the true static pressure of the lungs. When during normal tidal volume, normal mechanical ventilation, when a respiratory therapist checks the plateau pressure or static pressure, what we think we're checking is how the lungs are doing or how compliant the lungs are. When we do this, we're looking at the lung parenchyma, but we're also looking at the chest wall impacts those measurements. So if a patient has a stiff chest wall, they're just as likely to have a high plateau pressure as they are if they had a good chest wall compliance and stiff lungs. So if you've ever ventilated somebody with an acute abdomen and you've checked the plateau pressure, you've noticed that you've had a high plateau pressure and you've wondered and you've dropped your tidal volume if you've been following the ARDS-NET protocol. And you've questioned to yourself, do I really need to drop the plateau pressure because all the plateau pressure is coming from outside the lungs or their stiff belly or their stiff chest wall? The value of the esophageal balloon in calculating transpulmonary pressure is you can separate out which is lung and which is chest wall. And that is why some people say that the inspiratory transpulmonary pressure can be considered the true static pressure of the lungs. This is a screenshot of an AVIA ventilator during an inspiratory maneuver. You can see this is a inspiratory plateau pressure. This waveform, the second waveform, is your esophageal pressure. You go to end inspiration and you subtract your plateau pressure, or you subtract your esophageal pressure from your plateau pressure, and that gives you your transpulmonary pressure. In this particular patient, we see that their transpulmonary pressure is very high. The tidal volume is probably too much in this instance. So how this works at the bedside, given this example, we have this diagram here that shows this is the lung pressure, and the ventilator is measuring the plateau pressure, or the pressure inside the lungs. The esophageal balloon is measuring the esophageal pressure, which we're using as a surrogate for pleural pressure. So let's say, for example, I have a plateau pressure that is 45 centimeters of water pressure and an esophageal pressure that is 10. That gives me a transpulmonary pressure that is 35. In this instance, the tidal volume would be considered too high because most of the pressure is actually coming from the lung parenchyma. In the second example, given the same plateau pressure of 45, but the second value, the esophageal pressure, is 30, that gives us a transpulmonary value of 15. In that instance, the tidal volume would be okay because the distending pressure is low, and the high plateau pressure is because of pressure that's outside the lungs. Transpulmonary pressure at end expiration is pretty much the same method, except instead of doing an inspiratory hold, you're going to be doing an expiratory hold. And that can be used to guide PEEP management. So expiratory transpulmonary pressure is equal to your total PEEP minus your esophageal pressure. And in this instance, your goal is to keep your transpulmonary pressure equal to 0. And the reason is you want the pressure inside your airways to be equal to the pressure outside your airways. If you have a negative value, then the content that's outside your lung is pushing in on your lung, causing a lower FRC and de-recruitment. So in this schematic here, again, we have PEEP, which is the value, or the pressure inside your lungs. We have the esophageal pressure, which is the surrogate for pleural pressure. We're going to be doing the exact same formula. We're going to be subtracting the esophageal pressure from our airway pressure. So in the first example, we have a PEEP of 10 and an esophageal pressure of 15. This would give us a transpulmonary value of -5. In this instance, we do not have enough PEEP to countermeasure the pressure that's coming from outside the lungs. So we have a lot of pressure pushing in on the lungs, causing de-recruitment. In the second example, we have a PEEP of 10. We also have an esophageal pressure of 10, which is equal to 0. In this instance, the PEEP would be okay because the pressure outside the lungs is equal to the pressure inside the lungs. And this is how it looks on the ventilator waveform here. We can see that at end expiration, the total PEEP is 20. The esophageal pressure is about 6. If we subtract the 6 from the 20, we would have a end expiratory transpulmonary pressure of 14. In this instance, I would say that our PEEP is actually too high. You can also use an esophageal balloon to calculate work of breathing. In physics describes work of breathing as the amount of force required to displace an object. In the respiratory system, work can be described as the pressure change that is required by the patient or the ventilator in order to move a known volume of gas in the lung. And there is the formula for those of you who actually want to do it. It is measured in joules per liter. One of the challenges in doing work of breathing is you actually need a device that can perform this calculation. The VIA can do it, and the G5 cannot. How work of breathing can be useful at the bedside. Normal values for joules per liter is 0.4 to 0.6 for adults, 0.2 to 0.5 joules for pediatrics. And a work of breathing for the patient of greater than 9.8 has been associated with ventilator dependence and failure to wean. Some people have proposed measuring work of breathing during spontaneous breathing trials or workouts, and if they see that the work of breathing is increasing, then your patient is beginning to fail and you need to return them to A&B or their regular mode for rest. So reviewing some of the evidence for ARDS, we know that the current approach to patients with ARDS is based off the ARDSNet trial that was published in 2000. In that study, we targeted tidal volume that was 6 milliliters per kilogram of predicted body weight, and the goal was to keep the plateau pressure less than 30. If the plateau pressure was greater than 30, tidal volume was reduced until the plateau pressure was less than 30, or until you reached a low tidal volume threshold of 4 milliliters per kilogram. PEEP was managed by this PEEP FiO2 ladder, or the physicians were given the option of determining PEEP. To date, this represents the best evidence to managing patients with ARDS. In 2008, Dr. Danny Talmore and others, including respiratory therapist Ray Ritz, published an article in the New England Journal of Medicine entitled "Mechanical Ventilation Guided by Esophageal Pressure in Acute Lung Injury." This article turned out to be the main thrust for the interest in esophageal pressure monitoring and has also been considered controversial by some. In this study, they managed patients by using transpulmonary pressure. And the control group was managed by lung protective ventilation with the RRT trial and a PEEP FiO2 ladder. In the study group, they used inspiratory transpulmonary pressure to guide tidal volume management with the goal of keeping the inspiratory transpulmonary pressure less than 25. PEEP was set according to this and expiratory transpulmonary pressure FiO2 ladder. So the control group, for those of you who use a standard RRT PEEP FiO2 ladder, you'll be familiar with that. But in the esophageal pressure guided group, what they would do is they would set the PEEP until their end expiratory transpulmonary value was 0. If the patient remained hypoxic, then they would increase the PEEP until the end expiratory value was 2, or 4, or 6, or 8, or 10. They checked the esophageal pressure measurements once a day for 3 days, and then they compared the groups. So their study yielded some very interesting results. Their main outcome that they were looking at was oxygen indices, particularly P to F ratio. In this column here is the esophageal pressure guided group. We can see that their P to F ratio was significantly higher than the conventional RRT trial group. Some other interesting outcomes of this study was that the PEEP that they used was significantly higher in their esophageal group versus the conventional group. And also, the tidal volumes that were used in their esophageal guided group were higher than the conventional treatment. And if you also look down, the plateau pressure that was used by the esophageal guided group were higher than the conventional group. And I'll see if I can explain why we think that was. So in these two graphs, at the top here, we see at baseline, both groups had the same plateau pressure. Then the conventional group had a lower plateau pressure up to 72 hours. Now remember, they were using the conventional RRT trial protocol that said if your plateau pressure is over 30, you must reduce your tidal volume. In the esophageal guided group, they had a higher plateau pressure, but remember, using esophageal balloons, you can take out the element of the chest wall by subtracting the esophageal pressure. So in that case, the clinicians were probably more comfortable leaving patients on larger tidal volumes with plateau pressures over 30 because they had surmised that the applied plateau pressures were due to factors coming from outside the lungs, or like the chest wall. And this second one is the transpulmonary pressure at end inspiratory for both groups. And we can see that in the esophageal pressure group, they had the higher pressure, and in the conventional arm, they actually had lower transpulmonary pressures as they dropped the tidal volume. One of the most intriguing results of this study was the mortality. Even though there were only 30 patients in the esophageal guided group and the conventional group, the 28-day mortality almost reached statistical significance. It trended towards an improvement, which was very intriguing and also caused a lot of controversy. There are many criticisms of this study. It was a single-center study. The study had a very liberal PO2 range as compared to the RRT trial. If they had followed the RRT trial more ardently, many of the patients could have had their PEEP or FiO2 weaned in the study arm, which would have meant that they probably would have a decreased P to F ratio, again, which was the main outcome of the study. Harborview, we use these indications for esophageal pressure monitoring. We want to be able to assess for decreasing tidal volume below the 6 ml per kilogram threshold in predicted body weight for ARDS patients, and if they have plateau pressures over 30. So if the clinician wants to feel more comfortable about leaving a tidal volume at 6 mLs when their plateau pressure is above 30, you can use an esophageal pressure monitor to make yourself more comfortable with your decision. Also, if you would like to use PEEP or use the esophageal balloon to guide high PEEP management. We also may use it to assess for work of breathing during the weaning process, and also you can assess for auto PEEP during spontaneous breathing by examination of the waveform. Contraindications. Many of these contraindications deal with the placement of the catheter. The top two is if you're at Harborview, we don't cavalierly place these. We require the attending or fellow to order. Also, contraindication is inadequate clinician knowledge about interpretation. You really need to be able to have some skill in placing the catheter, taking the measurements, and then interpreting them. One of the major criticisms of using esophageal pressure measurements is that are they trustworthy during critical illness? The only available data on esophageal pressure monitoring previously has been done on healthy subjects and in a laboratory settings. We know that from those studies that the measurements can vary widely and are very affected by body artifact and position. There's a belief amongst many clinicians that the esophageal pressure measurements are invalid as pleural pressure measurements during critical illness. They just believe that there's too many confounders to reliably use esophageal pressure monitoring for a sick patient. The credibility of esophageal pressure monitoring as an estimate of pleural pressure was recently assessed by Loring and others. They did this as a simultaneous study with their esophageal pressure monitoring study. In their 48 critically ill patients, they had simultaneous measurements of esophageal pressure, gastric pressure, and bladder pressure measurements. And in this slide here, we're going to compare in their study. And their study was critically ill patients versus what were previously thought of as normal values. You can see that in the Loring study, the esophageal pressure measurements were much higher than what was previously thought of as normal measurements. Also, the gastric pressures were significantly higher, and the bladder pressures were also higher. This tells us that there's a difference in the pressures as measured during critical illness as compared to those previous studies that looked at mostly healthy subjects. This particular graph is from that study where they looked at the gastric pressure and the pressure that was measured at end expiratory in the esophagus. Because some people have mentioned, well, you can also just measure the bladder pressure and that will give you the transpulmonary pressure, or give you the esophageal pressure, and you can take the calculate transpulmonary pressure. In their study, they showed here that the values really didn't correlate. The R2 is a predictive indication of prediction, so there was only a 30% chance that if you knew the gastric pressure that you would know the end expiratory esophageal pressure. And part of that is the nature of the diaphragm. If you have a patient that has developed acute abdomen, the diaphragm can only stretch so much, and then it doesn't transmit as much pressure from the abdomen into the lungs when it's stretched. So the implications of that particular study is that measurements taken from the esophageal balloon tipped catheter can be taken as meaningful even if they are not exact or precise measurements of the pleural pressure. And clinicians should be cautious that those measurements can be used as approximations of laboratory concepts and can be used empirically to guide ventilator management. And further, the values may be useful in guiding ventilator management. A more recent study that looked at transpulmonary values during a decremental PEEP trial. In this particular study, they took 11 subjects that had ARDS. They were looking at the relationship between transpulmonary value, dead space, and oxygenation. And they did a decremental PEEP trial, which means they increased the PEEP to 30 and then reduced the PEEP in a stepwise fashion until they reached 0. And what they were looking for was what was the best respiratory system compliance, and could they figure out what was the best respiratory system compliance and what PEEP was that, and also what was the PEEP when the expiratory transpulmonary value was 0. Why I have this slide up here is because using the airway only or the best respiratory system compliant PEEP trial, there were 4 patients where the PEEP required to keep their transpulmonary value of 0 was higher than the PEEP that was used to determine the best respiratory system compliance. And the authors also found that when the transpulmonary value went less than 0, when it became negative, that PO2 precipitously dropped. That meant when the pressure outside the lungs was greater than the pressure inside the lungs, you de-recruited and your FiO2 dropped. This also is another slide from that same study. Here we have the PEEP recruiting up to 30 centimeters of water pressure, and as you can see, as the PEEP drops down to say less than 10, then the transpulmonary value goes 0 or goes less than 0 and probably is inducing de-recruitment. I have 2 case studies here. The first case study here was a 37-year-old female who had resolving TENS and developed necrotizing fasciitis in ARDS. The patient was on the lung protective protocol, the ARDSNet protocol, with a tidal volume of 250 milliliters that was calculated to be 4 mLs of predicted body weight. Her respiratory rate was 25 breaths per minute. She was on an FiO2 of 50% and had a PEEP of 10. The reason she was on such a low tidal volume was because her plateau pressure was 38. And she had a ABG that was pretty acidotic with a high CO2. She was a pretty challenging patient to manage. We placed an esophageal catheter and discovered that her inspiratory transpulmonary pressure was pretty low. It was 12 at the first measurement. Based on that decision, based on that measurement, it was decided to liberalize her tidal volume, and it was increased to 330 mLs. The new transpulmonary pressure was 17. The new plateau pressure, or static pressure, was 36. The next ABG showed marked improvement. The pH was normalized. She was still pretty hypercarbic, but her pH was normalized. In this instance, we discovered that using the balloon, we found a lot of the pressure was coming from outside her lungs, and that gave us reassurance that we could increase her tidal volume. And the second case study was a young man, a 20-year-old, that was in a high-speed motor vehicle crash who developed pulmonary contusions, a perforated bowel, close-hand injury, and had bilateral chest tubes. He was a pretty sick individual. He was on AMV with 490 tidal volume for 6 milliliters per kilogram, rate of 35, already on a pretty high PEEP, and already had a pretty high plateau pressure. The blood gases were concerning. He's already acidotic, rising CO2, but had a pretty low PO2. We placed an esophageal balloon and discovered that his inspiratory transpulmonary pressure was 17. So we were comfortable leaving him on the 6 mLs per kilogram. The expiratory transpulmonary value was -3, showing us that we had de-recruitment of the lungs. We increased the PEEP from 14 to 22, and that gave us an end expiratory transpulmonary value of 1, and our next blood gas showed marked improvement, particularly in our oxygenation. So to summarize, you can use esophageal pressure to approximate pleural pressure during critical illness. Using this requires specialized equipment and clinician knowledge to be used safely. More research will be required to establish the validity and best practice in using esophageal pressure monitoring to guide mechanical ventilation during critical illness. And more research is needed to determine if mechanical ventilation guided by esophageal pressure monitoring can impact mortality. And are there any questions?
Thank you, Carl. That was fantastic. And yes, we have quite a few questions. I'm going to take these in the chronological order that they came in, so we'll rewind a little bit with your content. So the first question is regarding the procedure of placing the esophageal balloon placement, placing that balloon. Is the pressing on the abdomen a procedure that's been recommended by manufacturers, or is this something that's been determined with evidence-based practice, or both?
I wouldn't say it's been either. I would say anecdotal practice. The manufacturer, when we originally first started doing this, had recommended a method of pre-measuring the catheter, but that proved to be a bit more challenging. There's no study that looks at placing, techniques to place the catheter. This has just been, kind of a best practice that we've developed through trial and error. There's essentially two ways you can place it. You can pre-measure it and then drop the balloon to your pre-measured location and hope that you're in the right spot, or you can just, advance it all the way into the abdomen, so at least you're in the abdomen, and then slowly withdraw it. It would be an interesting study, but I think anecdotally, based on my personal experience, I would recommend the pressing on the abdomen.
Thank you. This next question, I think the author had one meaning, but as I read the question, I kind of had another thought with it as well. So the original question is, what position should the patient be in when measuring pressure with the esophageal balloon? You mentioned that there is a change between the measurements in a supine patient and an upright patient. And we all know, of course, that the patient should be elevated to a certain angle to help prevent any ventilator-associated complications. Is there a special position that the patient should be in, A, while placing, and then B, is there a preferred position, or just being consistent with measurements once the catheter is placed?
The best position for placing the catheter is whichever one that you can actually get the catheter in. If it's the head of the bed up or the bed down, like I said, this is the one aspect of esophageal pressure monitoring that requires the most skill. We have quite a couple of therapists here that have gotten quite good at it. They used a couple of different techniques. One of the easiest tricks to placing it is to take an endotracheal tube, kind of cut it lengthwise down the center, remove the 4-light adapter, and kind of use that as an introducer. We've had challenging patients, so it's really, as far as placing it in the patient position, I would say the best position is the one that you can actually manage to get the catheter down in. As far as taking measurements, ideally you want the patient flat on their back with their head up to take off the compression of the balloon by the heart. Clinically, that doesn't always work out. We've had patients in rotoprone beds where you can't sit them up, or they're on spinal precautions. In those particular situations, I would recommend just being consistent in the way you take measurements. That if you're taking a measurement from Monday to Tuesday, the patient should be in the same position.
Thank you, Carl. That makes absolute sense. Yeah,
that
it does. It does. Another one of our participants asked if you could remind us of some factors that could increase chest wall stiffness.
One of the ones that I think I run into most commonly is massive fluid resuscitation. You have a patient, or trauma patients, or septic patients. A lot of the stiffness of the chest wall really just comes from the edema that's tightening the chest wall up. making it less expandable. Also, America has a obesity epidemic. Big bellies can increase it. It's not just, somebody's got a kyphoscoliosis or something. There's a lot of other things that impact the chest wall compliance more than just the chest wall itself, because it's also all the contents of the abdomen that are pushing up on the lungs that go into calculating transpulmonary pressure.
Thank you.
Does that answer the question?
Absolutely. The next question is about the Talmer study that you had talked quite a bit about. The question is pretty specific. Do you know if they utilized PV maneuvers to determine the LIP as a control for both?
If they used pressure, let's see if I understand this, to calculate the P-flex, I do not believe so. They may have done recruitment maneuvers, but they did not calculate the point of hysteresis. They used the end expiratory value to set PEEP.
Fantastic. So in our patients who are being monitored with the esophageal catheters, how do chest tubes at negative 20 centimeters of water pressure affect that transpulmonary pressure?
Well, the negative pressure, my guess is it would have dropped the esophageal pressure. Remember, the esophageal pressure is a globalization. So if you have a negative pressure being generated at one point, you will still have positive pressures being generated at other points. I think if you're going to try and take a measurement with chest tubes, you may want to put them to water seal during the time of measurement.
And that's a good point, Carl. I think that one of the things that I had to keep reminding myself when I was first learning about these catheters is that this is not a continuous monitoring piece. These catheters are used to take a measurement at a specific point in time. Am I right? Okay, great.
Correct. In fact, if you take continuous measurements, you can start to drive yourself nuts, because small changes in position, where the patient is in their fluid balance, can start to make you chase your tail, or you think you're going to be chasing tidal volume or PEEP. The best practice really, and this is how they did it in the Talmer study, is they took one measurement a day, and then they didn't measure it again until the next day.
So way back at the beginning, you had talked about icing the catheter. Can you give us a rationale for why you would want to do that?
To make the catheter stiffer. There's two brands that are out on the market. One's the Cooper Surgical, which you wouldn't need to ice because it actually has a stylet. The CareFusion, the Avia ventilator, has a proprietary esophageal balloon catheter that is a kind of a floppy material. Now, towards the tip, where it has scallops or holes in the end of the catheter, that once you've made a couple of attempts, particularly on a difficult patient, the catheter will start to warm up, and particularly around those vent holes, it'll start to kink. And then once it starts to kink in one point, it kinks more easily, and then you'll have to grab another catheter. So icing the catheter stiffens the catheter so that you can drop it into the esophagus a little bit more readily. It's very similar procedure to when the nurses are trying to drop an OG. I've seen them ice those, kind of where we got the idea. And it really it's just to make it easier trying to place it. I think the best trick that we have learned over the years is to take an endotracheal tube, cut it lengthwise, take off the balloon, take off the four-light adapter, kind of introduce it into the back of the throat, thread the balloon through it, and then once you get down into the stomach, kind of take the endotracheal tube off.
Fantastic. And this is the last question that we'll have time for today. We've talked about ventilator management improving patient survival rates a little bit longer, but do we have data that indicates that there's a significant difference in the eventual survival rate, morbidity or mortality?
I'm sorry, can you repeat that?
Absolutely. Do we have any data, anything that says that there is some sort of a significant difference in the eventual survival rate outside of the ICU?
Using
Correct.
the esophageal balloon? No. Dr. Talmore's study is the only one that's looked at outcomes in any fashion. And if you look at the 180-day survival rate, there was no statistical difference there. There was just a trend for 28-day mortality. This really is something that is early on in its sort of scientific life cycle. The next steps would be a multi-center randomized trial, which to my knowledge hasn't been funded yet. But there's really no evidence to say, you really can't make the comment that this impacts mortality or morbidity or any of that. The science just isn't there. It's not saying that it won't be. It's just not there yet.
Thank you. And Carl, thank you again for joining us today. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.